Okay, so let me start, Howard. Again, thank you very much for a really very interesting talk. As I understood from your talk and from the Q&A, the successful implementation of precision medicine involves a lot of moving parts to work in sync. And also, I think what I understood, it involves kind of a paradigm shift from short-term cost perspective to long-term benefit perspective. So now, translating it into Canadian or Ontario, whatever you prefer, context. So how do you think the experiences, your experiences at Intermountain, with value-based care and precision medicine, how they can be used in Ontario or in Canada? You can select the scope as you wish.
So one of the things that we did is long-term isn't very long anymore. So we looked at what is the economic benefit. If there wasn't a clinical benefit, we wouldn't even start the discussion. So this is all like, okay, there's a clinical case to be made. There's a clinical path that could be made. What does it look like in terms of the economics to the institution, both the direct costs as well as indirect in terms of taking people away from something else they might have done, et cetera. Is this going to benefit our patients in terms of not only outcomes but time and other points like that? One of the things that we did is we usually use a 12-month window. So the data that I showed you for cost savings for the whole genome analyses was in the first 12 months. And the reason we did that is a lot of our bureaucrats aren't sure they're going to be in their job 12 months from now, but they know they're going to be in their job less than that. So if we're in a window where they care, then they can't use that as an excuse. Because we used to come in and, especially with our newborn approach or childhood cancer, even young adults with cancer, you could have a 50-year window of savings and it could be just a huge amount of money. The people making decisions were thinking about this year's budget or maybe next year's budget, but nothing beyond that. And so that was a key piece of it. Also looking at what we then would not have to do. And so we really we kind of came to a 360-degree view of the problem. If we do something new, what is the clinical impact or the economic impact, like I just said, but what would we then no longer do? And often that was of as much or more benefit than otherwise, because it was a shift from from IV medicine to oral medicine, which now allowed us to ship the medicine to someone's home instead of them coming in and occupying a chair while we infuse them with that. And depending on your business model, that can be a good or a bad thing. But in our case, we don't make money by IV versus oral. It's all the same. And so we were able to go and look and say, all right, here's the following things that will happen. And then when we put that together, some of them are very difficult to put a dollar value on, but we can put time on them, and think about percent of FTE, a percent of employee time expenditure and that sort of thing. And so that's it ended up being much more complex. But I found that if we tackle the clinical and the direct fiscal part, that can now be the firm part of the equation. That can be stable. And then on that, we can look at all the other wiggly pieces and try to make them less wiggly, and then go forward. But if we just have one thing that's stable, the rest of it is very wiggly, and therefore wasn't. So we really tackled it in that way, that format.
Thank you.
That's excellent. I want to compliment you on the presentation and the very interactive Q&A that we had. Just following up on your talk, there's a lot of talk about learning health systems, and we are actively implementing a population-based learning health system for cancer in our region. Can you comment on just, there haven't been a lot of successful overall implementations, but the fact that you implemented this precision medicine construct through a whole health system that's quite distributed, can you mention some success factors from a learning health system perspective that enabled you to, well, not you, but your team, there's obviously a whole big team of people, to be successful? Or what are the necessary criteria to get to the starting gate, whatever version of that you think is appropriate?
Yeah, I think part of the key aspects of the learning health system is that the learning piece is not the same for everyone. As we're thinking about what a general practitioner needs to know versus a cancer specialist versus some of our genomic staff or our telemedicine folks for these special clinics we've designed, very different levels of learning that had to be, because the learning health system, it's almost more of a information health system, because you're really trying to keep people up to date and get their feedback and interact with them about how this should be moving forward. And so the learning is multiple directions. I'm learning and I'm teaching at the same, during the same conversations, but not requiring people to learn more than they need to learn. And that was once people realized that we were not going to drown them, we are going to give them bite-sized pieces that's enough for them to be able to benefit from what we're bringing. They then realized, okay, we can trust these folks. They're not going to teach us too much. They're not going to teach us too little. It's going to be a Goldilocks just right type of thing. And so I think that was part of the difficulty. I think that's why some of the learning health systems have fallen down, is that they've tried to make it a one-size-fits-all approach. They've tried to make it where you put things into a certain portal and you go to the portal, and it ends up being great on paper, but difficult to perform. And so I think that was one of the biggest lessons we learned, is to right size, for want of a better term, the learning depending on what the person's needs were.
Yeah, I think the corollary is precision learning.
Yeah, really.
Corollary,
yes.
Which is a corollary.
Yes. You should trademark that.
So I think the other thing that struck us is that your geographical service community or population that you serve ranges from academic center to small rural center. As you said, some places are 6 hours away from anything significant in terms of a health hospital and a major center. Can you just describe how you guys, from a cancer delivery perspective, precision medicine, immunotherapy, whatever version of that, how you guys have tackled delivering care or the medical care, oncological care over vast rural distances, and how you were successful with that?
Yeah. So there are some parts of it, the specialist surgery, for example, some of the radiation oncology, we don't have cyber knives at every hospital, that type of thing. Some of those are localized to elite centers, specialty centers, where one has to get to them for that. But we have made it so that the general surgeons, they know what they should not touch, but should be referred, and what they can go ahead and do, and we'll help them, support them in that way. It's the medical side where we've been able to make the furthest advances, because we can have a medical center where there's a nurse practitioner or a PA or someone who is living there in that area, have them go through enough training so they can properly administer, with the nurses, with the pharmacists that might be there, properly administer the medicines, monitor the patients, etc., with the medical oncologist, gynecologic oncologist, the specialty oncologist being available virtually. And so we do a lot of virtual visits now in geographic areas where we can't otherwise deliver that care for the medicine part of it. We have as many LINACs as we can around the place to make it so that radiation can be administered, but many of those centers, it's still a long drive, and so sometimes they'll forego what I think of as curative radiotherapy because they just can't leave their animals at the ranch for that long of a period of time, or some other stuff like that. So that's still an issue, but we at least can give them some care where they are. And the idea of treating people where they are as much as can be possible has been the real breakthrough. And that, the COVID pandemic aspects has kind of driven us to that, because we asked people not to come to us because we didn't want them to be exposed to things. It forced us to flip it around and say, all right, well, then that means we have to help them where they are. And that's sometimes satisfying, sometimes not, in terms of what we can deliver. But we've just tried to be as realistic as possible. But overall, patients now are able to get more and more things from their home, from a regional health center, than they were 5 years ago, because we've decided, well, we just need to do that. And, it's really about serving the people. When we look at what they want, they might want to come to the big city once in a while, and, after their clinic visit, they can do some shopping, but they don't want to have to be there all the time. And so, it's just say, well, what's the next best thing than them coming to us all the time? Well, it's us going to them. That's
amazing. Well, thank you so much. I want, on behalf of the Regional Cancer Program and the Telfer School of Business, we very much appreciate your time and outstanding. And hopefully we'll be definitely in contact. There'll be lots to share over time. And I know we already have one invitation to participate in our Northern Conference. And I'm sure we'll reach out more, because we are heavily pursuing, rolling out our molecular integration into our cancer clinical pathways. And so there'll be lots of opportunity to learn from you. So again, thank you very much. I appreciate it, Howard. Thank you.
Yes, anything I can do to help. I'd love to. Thank you so much, all three of you.
Thank you.
All right.